Dr. Drexler.
Thank you. Thank you, Dr. Jackson. Can you hear me? Can you all hear me? Oh, good. And I love what Dr. Early did by hanging out here and moving a little more. So if it's okay with y'all, I'd like to do the same thing. And I'd like to find out, I'm sorry I missed Dr. Potru's talks, and I realize there might be a bit of overlap. So y'all keep me honest if I'm telling you something he already said, and ask questions if I'm contradicting something he already said, because he was talking about opioids and substance use disorders as well. I have a short video, it's about 4 minutes, that I want to start with, and let me tee it up for you and tell you why it was developed and why I think it's important to start with this as we talk. So this video was developed by the father of a young man who died of a fentanyl overdose or fentanyl poisoning. And the story was this: he was an athlete in high school. He had an injury. His doctor treated him with an opioid for pain. And it got better. You know, he went on to continue playing in high school, got to college, was not college level athlete though, but he was doing well in college. He had plenty of friends. He was getting ready to interview for jobs. And he was playing intramurals, injured himself again, said, I know what to do with this, and I don't have time. So instead of going to see a doctor again, he went on to something like Snapchat or Instagram and ordered the same tablet that had been prescribed for him, took one, getting ready for an interview the next day, and never woke up. His father was a marketing executive, and so he was pretty good at telling a story and telling it succinctly, and he put together a nonprofit in his son's memory called A Song for Charlie. And this is the video, the short video that he produced to tell the public about what's been happening with counterfeit pills and fentanyl. So let's see if Lauren can tee it up, and we'll watch this together.
You've heard about pills killing young people, right? A teenager takes what they thought was a prescription pill and never wakes up. We're not talking about a drug overdose, accidental or otherwise. We're talking about being fatally poisoned by a single pill, one that looks like a legit Xanax or Percocet or Oxycontin. Except these pills aren't legit. They're counterfeit, fake. They can kill you within minutes. And it's happening all around you. The fastest growing group of victims is young and inexperienced. They take pills for different reasons. Some of them are experimenting, others are stressed out and self-medicating. Many victims died at home in their beds after swallowing just one pill. Every young person is at risk. So what's going on? We live in a quick fix, pill-popping culture, and we've been taught to trust prescription pills. In some cases, these medications are necessary, but they can also cause addiction. That's why we're in the midst of an opioid epidemic. So many people in the US became addicted to opioids that drug dealers started making fake pills to meet demand. The active ingredient of choice for these counterfeit pills? Fentanyl, a powerful synthetic opioid that's so potent it has to be highly regulated. There's no standard amount of fentanyl in these illegally made pills. They're not prescription medications. They're just thrown together in people's basements and garages with other cheap ingredients like filler powder and pressed into pill form. The dosage is never even. That's why they're so deadly. But fentanyl can be cheaply imported, and it's also highly addictive, which makes it ideal for creating fake pills. The drug cartels got involved too. They started to produce these counterfeit prescription pills containing fentanyl, known as fentanyls, on a massive scale, flooding the US with millions of fakes dressed up to look like the real thing. You can't tell them apart. Authorities can't fix this or make it go away, but you don't have to be the next victim. If you don't know where your pills are coming from, don't take them. Don't believe sellers on Instagram, Snapchat, TikTok, or any app. Don't believe friends who get pills from supposedly reliable dealers. Don't believe someone who says a pill has been tested. You may have heard of test strips that can detect fentanyl in illegally made drugs, but they're not reliable with pills, where fentanyl can be unevenly distributed. There's no way to figure out whether a pill contains fentanyl without grinding it up and dissolving it. In other words, destroying it. So if a drug comes to you in pill form, it hasn't been tested, period. And even if you test one pill in a batch, you have no way of knowing whether the other pills contain fentanyl. If it's not from a doctor or pharmacist, it's not legit. No random pills. Now you know the facts. Tell your friends, tell everyone you know. The more people who learn about fentanyls, the safer we're all going to be. You didn't create this problem, but you can be part of the solution. Help us spread the word. One pill can kill.
Great. Thank you, Lauren. Okay, that is a very sobering way to start this talk. I'm wondering how many of us have been touched in our practice. Who's lost a patient to an opioid overdose? Okay. How about in our communities? Who's lost a child at their local school? So we had an overdose at Dunwoody High School. You came to Atlanta, but let me tell you, you are in the edge city of Dunwoody. This is my hometown. And we lost a student in the classroom last May, right before graduation. It was devastating to lose a life, but to lose someone and have them die in class was particularly upsetting. As a community, the school, parents, everyone came together to support families and friends. They went to graduation, but we pulled together as a community to start the conversation around these counterfeit pills and around opioid use in general. And so I have a piece of good news. We did a community forum. One of the co-presidents of the PTSO came. She invited me to come do a training for teachers. And so their first staff meeting of the school year, I came and did a talk and talked about how to administer naloxone. And a week and a half later, they had another overdose in the classroom, and they administered naloxone, and the student survived. So I tell that story. That's just some of my volunteer work in the community. But talking with your patients about the risks of opioids, co-prescribing naloxone or nalmefene, or recommending strongly now that it's over the counter that they buy it, is really important for helping to save lives. And we'll get into more of the details. But I love being able to clean up this afternoon and follow. In some ways, it's really hard to follow Dr. Early and Dr. Tang and Dr. Potru because they're all such excellent speakers and experts in the field. But in another way, they've already teed up a lot of what I want to tell you. So we can go from here. So here we go. This is what we just talked about. So here's my outline, and it's ambitious, but we'll try to cover this together. You've seen the story about the opioid epidemic and how it's really grown. We'll talk in more detail about what we know from the epidemiology. But this idea of how we got here, I submit to you, has to do with opioid pain relievers and marketing. And as Dr. Early told us, there's a profit motive. The cannabis, the medical cannabis and the recreational cannabis, it's pretty close to the same in most states. Here in Georgia, we are protected because we still have a pretty strong law that the only medical cannabis we have is low THC oil. It's not inspected and regulated the same way FDA pharmaceuticals are, but it's closer than what most other states have. And we have no recreational cannabis laws. But it's coming, and there's a multi-billion dollar, if not trillion-dollar industry that's promoting that product because they can make a lot of money. So we will be seeing more of that. But let me tell you the story about the opioid epidemic. And then we'll talk about what can we do about it, and from my perspective, primary prevention, secondary prevention, and then tertiary prevention, which you may have the most questions about. How do we treat opioid use disorder? I'll be happy to talk more about. But I think this is a cautionary tale for us. So let me ask, before we get started, and you may have already known this, who practices in primary care? Okay, excellent. I know we have at least one ER doc. Any others? Okay. How about psychiatrists? Any other psychiatrists in the room? All right, yay. Let's see, OBGYN? Great. And surgeons, how many surgeons do we have? Wonderful. Any pain medicine specialists? Okay, who did I leave out? Neurology, excellent. Yes, thank you. I should have asked because I knew Dr. Early is a neurologist. Who else have I left out? Oh, hospice and palliative care. Oh, great. I know you do. And I'm about to say a few things about it that are maybe controversial, so I invite you to push back. But we'll talk about secondary prevention, so mitigating the risks in the patients who are on long-term opioids. And with palliative care, as we improve our treatment of cancer, what we thought was palliative care at the end of life sometimes turns into months and years. That's a happy thing. But it also complicates the management once somebody's on high-dose opioids. And so we'll talk a little bit about that, and then we'll talk about tertiary prevention. But I have been so fascinated. I got on this journey about the opioid epidemic when I was working for VA Central Office, but I've kept learning and reading more and more. And it's been fascinating and also quite disturbing, what I've learned. So let me ask you, when was the first opioid epidemic in this country? Just can't hear the answer, so you're gonna have to shout it out. 1904. 1904, that's excellent. I heard another guess up here. 19th century, yes. Okay, so there were the opium wars in the 19th century, absolutely. So thank you for that, because I think for most of us, time starts when we were born. So I was born in 1960. I remember the heroin epidemic in the 60s, vaguely, because I was young. And a lot of folks can remember, what was the problem drug when they were young, but we rarely go all the way back 100 years. But really in this country, the first opioid epidemic did start in the 19th century, in the 1800s. So let's go back and take a look together. First of all, though, I forgot I had this slide coming up. This is how we got here. So I don't know if you've seen this slide before. This graph was published by the Centers for Disease Control and Prevention in 2011. And what it shows, it's hard to read the fine print, is the thick blue line is opioid pain reliever deaths per 100,000 people. The top dotted line is opioid pain reliever sales in kilograms per 10,000. And then the dashed line at the bottom is opioid dependence treatment admissions. So we'll go in a little more detail about this, but all of us were told, the general public, physicians, that opioids were safe and non-addicting, and so we shouldn't worry about prescribing them long-term for chronic pain. And what this graph shows is actually they are addicting. As sales go up, so do treatment admissions, and they're not particularly safe because as sales go up, so do overdose deaths. So let's go back, though. Could we have anticipated this? If we lived longer than we do, and we had been practicing back in the late 1800s, we might have been able to predict this. This book was published in 1881, Drugs That Enslave. It was a metaphor that was very meaningful at the time, right after the Civil War, when we had gone to war to end slavery. the opium, morphine, chloral, and hashish habits. So that was the terminology at the time. It's a habit. Dr. Kane gave in table form, and I made this little graph for you, but this is one US city, and he's showing in orange the first bar in the bar graph. Can I point? Yep. That's the population. So the population didn't quite double, but this is the gold color is opium sales, the dark gray is morphine sales, and you can see that they have quadrupled or more, about 7 times, in the same 25-year period that the population hasn't quite doubled. So consumption of opioids at the time was really taking off. And Dr. Kane describes what happened, that finding pain, and at that time nervousness, hysteria, whatever, constantly claiming his attention, and that nothing relieves them so well as opium or its alkaloid morphia, which is 6 times as potent. The physician resorts to that use more and more, and hoping to sort of relieve the person's suffering, buy some time to find the underlying cause, and then eventually be able to help cure the underlying problem or at least mitigate it. However, once the patient is exposed to the drug and experienced relief, they insist upon further use of the drug, sometimes even feigning illness to procure it, and drifts rapidly into the habit, which was the term they used at the time. Today, thousands of educated and respectable people in all countries and all classes are habitués, and he named some famous folks like William Wilberforce. You ever heard that name? Do you know who that is? He was a member of Parliament and the leader of the abolition of slavery movement in the United Kingdom. Let's see, William Halsted, that's a familiar name. First chair of surgery at Johns Hopkins University, developed several surgical procedures, improved anesthetic and aseptic techniques, and it was his own research on himself for better anesthesia that led to him becoming addicted to cocaine and opioids. These were leaders in their field. They were not folks on the margins of society, but they exposed their brains to enough of these addicting drugs that they ended up addicted. The typical habitué at that time was an upper middle class housewife who had rheumatism or headaches. And once they were exposed to the opioids for treatment of their chronic pain, they became addicted. Okay, so what can we do about it? Just the first couple of bullets are just to illustrate the point even further. So in 1898, Bayer Pharmaceutical Company introduced heroin, which was their brand name for diacetylmorphine. And then a year later, they introduced aspirin. You can sort of see the marketing plan they've got. They all end in IN. And that's their brand name for acetylsalicylic acid. It's a non-addicting pain reliever that we still use today. But by 1910, Bayer had found that actually heroin was more addicting than morphine. And so they stopped producing it and stopped marketing it because the reputation was so bad. And in 1914, Congress passed the Harrison Narcotic Tax Act. And that was the first time in this country that we really restricted the public's access to addicting drugs. And there was a huge debate about whether to include tobacco, whether to include hashish, whether to include chloral hydrate. But they decided to restrict the top 2, which were cocaine and the opioids. And then Congress thought, well, you make it illegal, people will stop. We all know if you've had folks in your practice on opioids, it's harder to de-prescribe than it is to start prescribing. So the country couldn't turn on a dime, and even close to 20 years later, they were still having some legacy patients who had become addicted that they could not stop. And they still had the problem that there were some folks on the margins of society who were willing to break the law in order to use these substances, and other people who were willing to break the law to sell them. But it became illegal gradually over that 20 years for physicians to prescribe narcotics to narcotic addicts. That's the way it was phrased. And Congress then felt compelled. Other advocates said, well, it's inhumane to just stop these medicines abruptly, you need to provide treatment. So they funded 2 prison hospitals, the U.S. Narcotic Farm. They put them out in the country where they thought the fresh air would help with the healing. And the one in Lexington, Kentucky was also funded to have a clinical laboratory where they studied and tried to develop effective treatments. They had a limited success. They got pretty good at detox. They tried different things for rehabilitation. And in this clinical laboratory, they described opioid tolerance and withdrawal as being important drivers of continued opioid use. Once someone developed tolerance, if they tried to cut back or stop, they suffered withdrawal symptoms, and that kept the addiction going. For the researchers who were not experienced with addiction themselves, it was easy to see how miserable someone was during opioid withdrawal and to understand it. So they really felt the tolerance and withdrawal were the more important drivers. We now know, as Dr. Early talked about, with the cocaine epidemic, where the withdrawal symptoms are not so obvious, that there's a positive reinforcement, that incentive salience that he talked about, that's also important. But tolerance and withdrawal and the negative reinforcement of relieving withdrawal immediately is very powerful. So by the 1960s, when this heroin epidemic was really getting going, iatrogenic opioid dependence was really rare because we had changed our practice. We used opioids in a very circumspect way for severe pain, moderate pain, for a very limited amount of time, the lowest possible dose for the shortest period, usually perioperatively or for painful conditions like kidney stones or injuries. In 1962, though, there was this heroin epidemic, and people were dying on the streets of New York City, Baltimore, Philadelphia, and some researchers in New York, Dole, Niswander, and Creek, took the methadone that had been developed at the narcotic farm and said, instead of just using it for detox, what if we used it for maintenance? And so the idea was, because methadone has a slow onset of action, you get less of a rush, less of that euphoria. Because of the long half-life, it tapers off, and you can dose it as little as once a day. And so that need to constantly chase the withdrawal symptoms with multiple doses of heroin every day is eliminated. The person can come to the clinic once a day, their life is normalized. It was very effective. And it also got us thinking about, well, maybe we can prescribe opioids long-term, and it might work out okay. And then the palliative care movement came. And there was this perceived undertreatment of chronic pain. It took some laws, and so advocates for this went to state legislatures and passed laws in greater than 20 states to allow the use of opioids for chronic pain. And so even though recognizing that tolerance and withdrawal were part of opioid dependence, and that they said, even if these chronic pain patients have developed opioid dependence, we want to be able to legally provide this compassionate care. And so they did. And then several experts, you may have heard of this letter to the editor in the New England Journal of Medicine, Porter and Jick. It was promoted by OxyContin's sales reps and others as evidence that it's safe. But this was a case series of folks in the hospital who were prescribed narcotics for their pain in the hospital, and they reported that less than 1% left with a discharge diagnosis of an opioid dependence. That's really not surprising, but it doesn't tell us much about how to manage chronic pain. Roger Chu also noted that the average dose was less than 20 milligrams of morphine equivalent daily dose. In 86, Russell Portnoy talked about the low risk of abuse in palliative care settings, and that was also highly promoted by the opioid pain manufacturers. And then in 1989, Weissman and Haddix wrote a paper on pseudo-addiction. And this was one case report of a 17-year-old with leukemia who came into the hospital. Over time, he was irritable and demanding. His pain became more diffuse. They called in the pain management experts, and they said, increase his opioids. They did. the patient settled down, and as his infiltrates resolved, so did his demands for pain, and they were able to lower the opioids very successfully. So, and that's a very happy story about not being so quick to diagnose an addiction when you see signs like irritability and more diffuse pain complaints. But it's only one case, and it's not really talking about what's happening more often. And then in 1996, Purdue Pharma introduced OxyContin, which was FDA approved for cancer pain. But here's an interesting thing about how these products are marketing and kind of the cat and mouse game. So at that time, you all know, if you can get FDA approval, it means that the medicine has shown some safety in healthy folks, that's phase 1 trials, some safety and efficacy in folks with the disease, that's phase 2 trials, and then in phase 3, the randomized double-blind placebo or gold standard control trials, that it's more effective than placebo and it works. So OxyContin had passed that test for treatment of cancer pain, palliative care, but you also know that it's perfectly legal for us to prescribe an FDA-approved medicine off-label. And they immediately started promoting it for other use, really without the research. So, and what the marketing plan says is, this market for cancer pain, that's about 7 million patients, and it's a crowded marketplace. There's lots of competitors. If we want to get to our first $1 billion in 5 years, we've got to reach out to a different audience. There are 35 million back patients, and nobody's in this space. So let's start working on that. This is my next slide. So this is straight from their marketing plan. Here's their OxyContin sales goals, and you can see in 96 they didn't expect much, but by 2001 they were hoping to have $1.4 billion in sales. And the reason I know this is because they've been sued, and part of the lawsuit has made these records public, and the Kaiser Family Foundation has published it on their website. So it is mind-numbing to go through these reports, but you're free to do so. A lot of it's been redacted, but I just want to point out a few things. For patients, so they realized within the first year or two that it was not going to be easy to move into the back pain space because patients and their providers were worried about addiction. So for patients in 1997, they funded something called Partners Against Pain, which would help tell the stories of patients who had had successful treatment of their pain with OxyContin. And then for providers in 97, they had a $250,000 education grant to develop consensus guidelines for opioids for non-malignant pain. And then in 1999, $90,000 for these terminology visuals for addiction, physical dependence, and tolerance. And so that was kind of odd to me, except for the next statement. This 2001 American Pain Society, AAPM is the American Academy of Pain Management, and ASAM is the American Society of Addiction Medicine. So experts from these 3 organizations came together and made a consensus statement that says physical dependence, withdrawal, and tolerance and addiction are discrete and different phenomena that are often confused. I can trace the history of how we diagnose opioid dependence and opioid use disorder all through this period. That was never a thing until the marketing plan for OxyContin says we need to distinguish these things, and then the consensus statement says we need to distinguish these things. And so we believed it. Most specialists in pain medicine and addiction agree that patients treated with prolonged opioid therapy usually do develop physical dependence, which is their term for withdrawal, sometimes develop tolerance, but usually do not develop addictive disorders. There were no references, there was no peer review. It just appeared on the websites for all 3 of these and was highly influential. So back to the epidemiologic data. This is from the CDC, and this is their overdose data. And 3 waves of opioid overdose deaths were really introduced by exposing enough of us in the general public to enough opioids. So I want to walk you through this just a little bit. So remember the graph from the CDC, how opioid sales went up and so did prescription opioid overdose deaths. What I'll point out here is any opioid death is the top gray line. The blue line in the middle, and these colors don't come out very vibrantly here, but this blue line, this is opioid pain reliever deaths. And in 1999, they already overshadowed heroin-related overdose deaths. But most of the graphs you'll see pick up in 1999, but that was already halfway through the story. And they keep going up from 1999 until about 2011, when that CDC publication came out. And lots of alarm bells were starting to go off. We started to be more careful about how we prescribe opioids, and the deaths started to come down. That was very rewarding. At the same time, though, as they talked about in the video, heroin deaths started increasing because the drug manufacturers, the illicit drug manufacturers, knew there was this new market, this drug hunger that had been created, and they had a solution. And if you've ever read the book Dreamland, they would deliver black tar heroin like pizza. You didn't have to go into some strange neighborhood that you knew had high crime rates to find your heroin. They would deliver it to you in the McDonald's parking lot. So that started coming up. And then out of nowhere in 2013, this third wave, which is the purple, is the synthetic opioids, because it's so much more potent. And they started cutting it first into any white powder that they sold and then pressing it into the counterfeit pills. And it has taken off at an unprecedented slope. And that's what's brought us to the state that we are today with the counterfeit pills, driving so many of the overdose deaths. So this slide is also from that same CDC database. I just want to point out the orange and yellow lines here, the same opioid lines that you'll recognize. There's the prescription opioids in the blue. The orange is cocaine deaths. Cocaine on its own can be deadly, as you know, cardiac arrhythmias, strokes, but it has come and gone at a sort of a lower level. The green line is the benzodiazepines. They also can be deadly, but usually they have to be mixed with another sedative like alcohol. But the green line has taken off, the orange line has taken off, and this methamphetamine has taken off because the illicit drug manufacturers have been pressing fentanyl into the counterfeit stimulants that they're selling as well. It's not just counterfeit opioids. Okay, so that's my version of how we got here. And I welcome questions and discussions about that. So what can we do to prevent this? And I think one important answer is opioid-sparing pain care. So the CDC has published clinical practice guidelines for prescribing opioids for pain. The first one came out in 2016. This is the most recent one in 2022. And there's a statement in the introduction that I really appreciate. All patients with pain should receive treatment. It should be compassionate and balanced so that the greatest benefits with the least risks. So how do we do that? First of all, non-opioid therapies are at least as effective as opioid therapies for many kinds of acute pain. So a lot of dental procedures that routinely folks were getting opioids, now we know can be managed with just NSAIDs and ice. Same for many injuries. So we're doing a much better job. I've lost my ER doc here, but we're doing a much better job of treating pain without opioids in acute settings. And then their second recommendation is non-opioid therapies are preferred for subacute and chronic pain. The VA DoD guidelines go a step further to say we recommend against initiating opioids for chronic pain. But for those legacy patients that are already on opioids, we also recommend against abruptly stopping. And if the benefits are outweighing the harms for your particular patient, talk with them, educate them about risks, do things to mitigate risks, but don't abruptly stop and don't feel pressure that you have to stop the medicines. Okay, and why did they change that? Both of these guidelines, the VA DoD and the CDC guidelines, are based, as Dr. Tang said when he was talking about his recommendations around alcohol, it's based on a review of the literature that's extensive. And they rate high-quality studies more heavily than low-quality studies. So a case report or a case series doesn't get as much weight as a randomized controlled clinical trial. This is the SPACE trial out of the VA in Minneapolis. Erin Krebs is a primary care doctor. She's the first author and principal investigator. But it was a multi-center trial. They randomized 240 patients with osteoarthritis or back pain to receive either NSAIDs, which I think was a naproxen, or opioids. And then they used this collaborative care management to try to follow the current guidelines at the time of minimizing the dose, the lowest effective dose, maximize non-pharmacologic and non-opioid pain regimens. And then they went on to see, were opioids actually better at treating the pain? And what they found, so that the patients and the providers were not blinded to assignment. They felt that was important for being able to do the collaborative care. They also didn't kick folks out of the NSAID arm if they used any opioids. They just monitored how much of what everybody used. So they found that the average opioid dose was 26 milligrams in the opioid arm and 1 milligram morphine equivalent daily dose in the NSAID arm. And what they found was no difference in function at any time point. But I want to point out the pain intensity perceived by the patients. Both sets, both the orange, which was the opioid, the orange, which was opioid, and the blue, which was non-opioid, they both came down significantly over the first 3 months. That's a really nice trend. They're getting relief. But then what happens after that is for the opioid arm, there's really no change for the next 9 months. Whereas those on NSAIDs, their pain continues to gradually go down so that there's statistically significant separation by 12 months. What they did find, though, and I didn't supply the graph for that, is that adverse events were also significantly worse in the opioid group. So after 20, almost 30 years of promoting opioids as being better, stronger, the more effective medicine, we had not had a comparative effectiveness trial until this SPACE trial. And it showed really there's no difference. And opioids perform a little bit worse over the long run. So opioid-sparing pain care to the degree that it's possible and humane and compassionate. And then secondary prevention among those who are on long-term opioids, educate the patients about the risks of overdose, recommend or prescribe naloxone, mitigate risks in other ways, lowest effective dose, monitor their use, do periodic, random is better urine drug tests. If they come back positive for something you're not prescribing, please don't fire the patient and stop their opioid right away, but work with them. Treat the co-occurring substance use disorder. If it's another opioid that's appearing, then maybe what they need is medication for their opioid use disorder. If it's another substance like cannabis or a benzodiazepine, something that you don't expect, talk with them about that, educate them about the risks. Try to determine, Dr. Early gave some great examples of things you can do, but treat the co-occurring substance use disorder. And don't fire your patient and leave them without opioids. And then shared decision-making around both initiating, increasing, and tapering the opioid doses and benzodiazepines. So let's talk a little bit more about that. I talk with patients, I educate them about what opioids are. Dr. Early has done a much better job than I could do about talking about how opioids are addicting in the brain. But for me, what seems to resonate with patients is I say they mimic neurotransmitters that happen in our brain to help one brain cell talk to the other. But those signals occur naturally on the order of milliseconds. any of the external opioids that we take in activate those receptors for minutes to hours. And that's actually not natural. It doesn't matter whether it comes from a naturally occurring substance in the opium poppy, sorry, I'm tongue-tied, or whether it's semi-synthetic or fully synthetic, it's activating receptors in a way that they were not designed to be activated, and the brain adjusts. And everyone who exposed their brain to this phenomenon will have some changes that happen, and it depends on how long you're on the medicine. It depends on how high the dose is. The longer and the higher the risk of becoming addicted. But becoming addicted is not the only risk. There's also constipation, there's also bowel impaction, there's also falls and breaking your hip. Lots of negative consequences. Addiction is one of them. All opioids are potentially addicting, and all can cause death by stopping breathing. So you know these, the opioid acute effects. We start using them because they treat pain. They also are really superior cough relievers over the short term. People use them illicitly because of the euphoria initially, but also because they're self-medicating anxiety or depression, as the video said. And I teach my patients what are the signs and symptoms because I want them to be able to recognize an overdose and to be able to act. And then I talk about chronic use, that for medications that I might prescribe like buprenorphine or methadone, part of the point is to build up the tolerance to the point that if you buy any illicit opioids, you're not going to feel anything. But once you have tolerance, then if you try to stop on your own abruptly, you're going to experience withdrawal, and it's pretty miserable. So that they know what they're getting into. And then also so that they know if they administer naloxone and it's effective in reversing an overdose, they may actually precipitate withdrawal, and their friend or loved one might not be happy about waking up vomiting and in muscle spasms and in pain. So be aware and don't be surprised. I talk with them about the difference in potencies so that they can recognize why fentanyl is such a threat. Morphine, we learned from Dr. Kane, is 6 times more potent than opium. Heroin is twice as potent as morphine, but fentanyl is 100 times more potent. And carfentanil is 10,000 times more potent. Again, I encourage my patients, if they have substance use disorders, even if opioid use disorder is not their primary addiction, that they should carry naloxone because they never know when they can save a life. And here in Dunwoody, in our high school, one of the students was so moved by what happened that she decided to start a nonprofit to raise money to put naloxone in every classroom. And we now have naloxone in every classroom. So what about informed consent for opioids? I think this is from my experience working with primary care and pain management in big VA, at VA central office. It's really important to inform patients with chronic pain about the risks of developing an opioid use disorder, as well as the other risks that you are used to talking about. And then I think it's important to talk about the signs and symptoms of an opioid use disorder, or I think even more concisely, I'm a fan with Dr. Tang of the WHO, because that's only 6 features to remember instead of 11. And then to tell them, opioids aren't the first-line treatment for chronic pain, and over time, daily opioid use can build up this tolerance and make pain worse over time. And increasing tolerance, we now know, we didn't know 20 years ago, but we now know that increasing tolerance is a sign that it may be hard to stop. And so if it's at the end of life, that's a different situation. But for someone who's got 20, 60 years of life ahead of them, this may start to cause problems. Encourage the patient to express any concerns and questions and reassure them that you want to work with them, and prevent and treat any emerging opioid dependence. It doesn't mean you're going to fire them or abandon them. You can actually provide treatment or connect them with someone who can. And then this was an important consideration that I never thought about, but you may have in your practice, medical amnesty. A lot of patients are concerned that if they administer naloxone and something goes wrong, they can be arrested or sued. So in Georgia, I don't know about our surrounding states, we have a medical amnesty law, and part of that is it expands access to naloxone. First responders were concerned, police officers were concerned, firefighters were concerned. So now in the law, we have protection. If you're trying to save a life with naloxone, you will not be arrested or sued. And furthermore, if you are using with someone and it's just the amount of drugs that you have in your possession is just personal use, not enough to make the police think you're a drug dealer, and you call 911 because your friend has passed out and you can't wake them up, you will not be arrested for a small amount of drugs. Don't hesitate to call. But then I would also say to my patients, don't use with your drug dealer because they know this. They might not call 911 because they know they could still be arrested. So there's a lot to the law. There's, ins and outs. And there's more information at that website for Georgia's law. I would encourage you to learn about the law in your state if you're not in Georgia, and just encourage patients to carry naloxone with them wherever they go. If you're prescribing opioids for chronic pain, that they have it on them. They're not intending to overdose, but it could happen, and their loved ones need to know about it. And then tertiary prevention, which may be what you wanted to know most about, is how do you treat the complication of addiction once it happens? These are 6 features for the WHO diagnosis of opioid dependence, which I've also found is also a more palatable term for many patients than opioid use disorder. I've had patients tell me, yes, doc, I've become dependent on this medicine that's been prescribed for me, but I don't have a use disorder. I'm not disordered in how I use it. I take it as prescribed. But if they're starting to develop these symptoms, they may benefit from switching from full opioid agonists to a medicine like buprenorphine, which is safer in preventing overdose. So a strong desire to take the drug, intrusive thoughts about the next dose at the end of the dosing interval, difficulties controlling use, taking a larger dose than prescribed, being unable to stop when it's indicated, someone who's almost died of an overdose saying, I've got to have my opioids back. Repeatedly driving when it's unsafe to drive. Persisting in opioid use despite obvious harmful consequences, and giving up more important activities. That's what Dr. Early was talking about earlier, that it's gradual and subtle and folks don't notice it, but the opioid starts to take a more and more important, be more motivating than other things that are really more important. And finally, the physiologic withdrawal state and the tolerance. Notice that you need 3 out of these 6 to make a use disorder diagnosis. So if your patient on opioids for chronic pain only has tolerance of withdrawal, that would not be a reason to diagnose an opioid dependence and start treatment for that. What if someone has developed opioid dependence? This is my summary of the reasons why. Offer medication. So medication reduces the risk of relapse, looking at all studies, by about 50%. Compared to placebo, it improves retention. One of the early clinical trials where they randomized patients to buprenorphine sublingually versus placebo, they had 0 patients left in the placebo arm at the end of the trial. They had 75% of the buprenorphine patients remaining retained in treatment. They had 3 overdose deaths in the placebo arm and none in the buprenorphine arm. Medication also reduces the risk of overdose death by about half in the general population. This study by La Rochelle and colleagues in Massachusetts, they combined 7 different databases to see who was prescribed what, and they followed them month by month, who was on medication versus not. Just getting started on buprenorphine or methadone maintenance treatment, that's the MMT, reduced the risk of dying in the next 12 months by 60% for methadone, by 40% for buprenorphine. And I can tell you that most of the patients did not stay on the medicine the whole time. If they did, the few folks who stayed on for 12 months, Naltrexone also saved lives. It's just people stop it a lot sooner than the buprenorphine and methadone. And it greatly reduced 80% or more for the folks who actually stay on the medicine. Counseling and mutual help helps, but I've also had the experience working with the entire VA of providers who would say, well, if you don't go to counseling, I'm stopping the medicine. The medicine saves lives. The counseling helps, but I wouldn't stop a medicine that's saving someone's life because they won't go to counseling. And detoxing without initiating one of these maintenance medicines really sets someone up for overdose and death because we've lowered their tolerance. Dr. Early taught us about why they're still going to have this drug hunger. The wanting has increased. They don't have the external controls provided by a medicine, and they're at high risk for relapse. But now with the lower tolerance, they're at really high risk not to wake up. There are 3 FDA-approved medications, naltrexone, which can be prescribed by mouth, but I don't recommend it for opioid use disorder. I do recommend it for alcohol. But the risk-benefit is just so huge. If their tolerance has been lowered while they've been on naltrexone and then they forget to take their pills for a few days, they're going to be at high risk for dying of a slip if they have a slip. So the injectable is better. You can even incentivize them to come for their monthly injections with some kind of reward and keep them on it long term. Those who don't have tolerance or those who prefer to be opioid-free, those are the best patients for it. Buprenorphine, though, if you have a patient who just can't stop and this withdrawal, intermittent withdrawal is the big problem, you start the buprenorphine in your office, relieve the withdrawal, they're so grateful. You can get them up to a stabilized dose within a few days, and most folks are maintained on 12 to 16 milligrams, sometimes higher if they have a higher tolerance. Methadone is a full agonist. It causes slowed cardiac conduction. It interacts with a lot of other medications, so those are the reasons why it's so highly regulated. And so they can only get that in an opioid treatment program, and those are not widely available. But I reserve that for my patients who haven't been able to achieve long-term sobriety on buprenorphine or naltrexone. And that's the end. I have all the references. Hopefully I understand you're going to get a copy of the handout so y'all can look at them up if you want, and I'll pause for questions.
Questions? Whoa. Yeah, okay, Doctor. Thank you.
I just wanted to comment that I was real impressed with the video that you started with. I was wondering, how can we get that out more for helping other communities as well as this?
Thank you. So if you just Google "one pill can kill," one of the first things that comes up on Google right now is a DEA website where they've put together, this is their campaign, "One Pill Can Kill," and they have a link to A Song for Charlie. So it's there. I mentioned the overdose death that we had here at Dunwoody High School. Good news, as I said, is I did this training for the teachers, and they asked the same question. And what I didn't realize until yesterday is one of the things they did at an all-school assembly was they showed that 4-minute video. And the kids got it. I showed it for a parent and student assembly yesterday, and the parents were all saying, wow, this is great. Where can I get this video? And the kids were like, oh, I've seen it before. But I agree with you. I think that is such an amazing video. And there are so many parents who have turned their grief towards wanting to spare other families the same pain and are doing some amazing work in this space.
Other questions?
If you found this content valuable to you, please consider joining SMA by visiting sma.org/membership or making a tax-deductible donation. Visit sma.org/give to support our mission. Thank you.